And our guest tonight is Dr. John Puntis, who recently retired as a paediatrician with Leeds Health Authority. He's worked for the NHS throughout his career, mainly here in Leeds, and he's passionate about keeping the NHS public. He was one of the founders of the Keep the NHS Public campaign in Leeds, and I think he's co-chair of the national organisation at the moment. Is that right, John?
Correct, yeah.
So. Good. Right. He's going to speak about on the subject of privatisation of the NHS and does it matter, with special reference to the events that have happened during the COVID pandemic. If you've not joined us before, I'm just going to say a little bit about the format of the evening. John will talk to us for about 45 minutes, and then we'll have a break, 10 to 15 minutes, during which if people can mute themselves, otherwise we get lots of background noise of people drinking things and dogs barking and things. After the break, we'll have questions. And if you want to put a question on the chat, you can do that by clicking on the chat at the bottom of the screen, if everybody can see that. And you can write your question in while John's talking or during the break, and then we'll have a discussion afterwards. If you prefer to ask your question in person, then there'll probably be an opportunity later on. Before we start, I'll just mention our next meeting, which will be on Tuesday, the 5th of April. The subject hasn't quite been finalised. But it will be online on the 5th of April, and we'll send everybody details near the time. So I think that's all I need to say. So I will welcome John now, and thank you very much, John, if you'd like to start.
Thank you, Priscilla. So I'll open my PowerPoint. Which hopefully you'll be able to see now.
Yes, we can see.
So I'm not going to spend too much time on the pandemic, although I will come to that. So this is what I'm going to speak about. What is privatisation? Because it's very contested. Where is it? So that's a kind of walking tour around Leeds to give you a flavour of what's going on. And then I need to go back right to the origins of the NHS and talk about how we've got where we are now. And then a little bit about NHS finance and the impact that that's had on services. The Health and Care Bill, which is currently before Parliament. And then sum up with why I think privatisation does matter and why people continue to pursue what's really, in my mind, a failed policy. So here we have a World Health Organization definition of privatisation. And you can see it's very broad, but this is the one which I think is very useful. A process in which non-governmental actors become increasingly involved in the financing and or provision of healthcare services. Now, there are 5 types you can see there: outright sale of public assets, contracting out to for-profit or not-for-profit private providers, self-management, autonomy to generate and spend resources, market liberalisation to actively promote growth of the private sector, and withdrawal of state provision leading to growth of the private sector. We have all of those. The last one is probably to the fore at the moment. And what's interesting about this is if you talk to the government or if you talk to people in the clinical commissioning group or the health partnership board and mention privatisation, they look at you as if you're mad, and they say they don't think there is much privatisation and they don't think it represents a threat to the NHS. And I think that's because the government know that the public doesn't like privatisation. And so they get round it by saying, actually, if we use taxpayers' money for the NHS to buy in services, that is not privatization. And that's how they make the argument that there actually isn't much privatization going on. So now I'm going to take you on a walking tour of Leeds. And these were, I went round and I took photographs about privatisation in Leeds. So this is Quarry House, NHS England headquarters. And NHS England is really a quango that's been reshaping the NHS with the help of private companies. It's very striking that there's a revolving door system with public-private partnerships going on with politicians, civil servants and managers moving in and out of lucrative posts in higher management and in big health companies. And perhaps most notably, Simon Stevens, now Lord Stevens, who's moved off to the Lords, but who worked for United Health in the States for 10 years, a huge American health corporation before becoming head of NHS England. So we're right in the middle of things in a sense in Leeds. And then these are the offices in Leeds of the 4 big management consultants. So PricewaterhouseCoopers, Deloitte Touche Tohmatsu, Ernst & Young and KPMG. They're constantly involved with NHS contracts, with being given billions of pounds to do bits of work in the NHS, and epitomise the use of management consultants, which has become so common. A few years ago, as auditors, they actually failed to predict the dramatic final collapse of Carillion, a hospital builder. This cost the taxpayer 148 million. In 2014, and I don't have up-to-date figures, but I don't think it will have changed, 2014, 640 million pounds went on management consultants in the NHS. And in the Leeds Teaching Hospital Trust, there used to be a recurring expenditure every month for training, which was £120,000 a month, every month. And when I asked what this was for, because it had gone on for years, it was for management consultants. Now, look at those pictures of the offices of the Big Four, and I'm going to show you a couple of pictures of the infirmary now. This was my office entrance for many years, working in an old building, probably had asbestos in it, almost certainly had radioisotopes in, because it had been the Department of Nuclear Medicine. And there were about 70 of us in that building. When it rained, the rain used to come through on my desk. This is another picture. This is the Gilbert Scott building, a snapshot from the outside. It is even worse inside. There's no patients in there now, of course, nothing in there. It's empty by and large. But this gives you an indication of what's happening to NHS estate. There's definitely no money for spending on old buildings like this, which I think is a tragedy. But actually, there's now a 10 billion backlog in maintenance work in the NHS because the money has been so tight, it's been neglected. That means that there's now critical maintenance issues around that are impacting on patient safety. These include fire safety hazards, sewage leaks, falling ceilings, things which pose a genuine threat to patients. This is the Bexley wing at St James's, the Yorkshire Cancer Centre. It's around one of 100 facilities that were financed by the Private Finance Initiative. Now, hospitals are now paying crippling amounts. They're actually having to fork out £80 billion for what was £13 billion worth of investment by the private sector. Most people now regard PFI simply as a scam, and 9 out of 10 of the PFI bills are effectively owned by international investment funds. Private companies have become embedded in NHS facilities, and there's a lot of blurring of the boundaries between private and public. These are two pictures, but if you go into level 4 in the Bexley, you see the signs for Nova Healthcare, which is the private cancer facility within the Bexley wing. A few years ago, Leeds Teaching Hospitals included adverts for Nova private healthcare with outpatient clinic appointments for NHS cancer patients, which basically said if you wanted really top-class care, you should go to Nova. It's convenient for the company. They actually describe St James's, or this wing, as their hospital on their website. They get access to NHS cancer consultants. And one of the benefits for the trust is that they get access to state-of-the-art scanning equipment, which, because of the capital restrictions in the NHS, they can't afford otherwise. And we're now just about the bottom of the 26 OECD countries in terms of things like scanning equipment. It's old and outdated, and it's few and far between. Also, the picture on the lower right there, Ward 30, there are 2 wards that are run by Villa Care, step-down wards, but run and staffed by Villa Care in St James's. Relatives complained to the CQC, Care Quality Commission, about those a few years ago. And in 2019, the CQC found that they required improvement in all 5 domains that were assessed: safety, efficacy, caring, responsiveness, and leadership. This is one of the many care homes, private care homes in Leeds, near Roundhay Park. Residential social care has become almost entirely removed from the public sector. The big companies that run the majority of the large homes, their unstable financial model involves hedge funds, very high levels of debt, and very high levels of premiums for investors. They expect something like a 12% return on their investment. This spells instability and future disaster. And a few years ago, Four Seasons Healthcare, one of Britain's largest care home groups, went into liquidation. This is the Spire Hospital in Leeds. At least a third of the income now for private hospital sector, and half their patients come from the NHS, paying for surgery to be done in these hospitals. 30% of hip operations, 20% of cataract operations are funded by the NHS. Over 2 years, Spire, as a company, spent £1 million just on gifts and hospitality for consultants in order to attract business from referring doctors. In a highly critical report by the CQC a few years ago, it found Leeds Spire Hospital requires improvement. Private hospitals are mostly small in scale. They average 46 beds. They have about 8,000 beds in all. This is the Nuffield Hospital, conveniently close to the infirmary, make it easy for consultants to go there, and of course also to access intensive care facilities, because private hospitals in general do not have intensive care. They cherry pick patients who are not likely to become severely ill, and they ship out their very sick patients to the local NHS hospital in general. That costs the NHS about 20 billion a year, I think. Maybe not that much, 20 million, a significant amount. I don't know what this what this sculpture is outside, or what it's called, but I think it probably ought to be called Lost Souls, or Souls in Torment. That's kind of what it suggests to me. Now, this is Millgard Hospital, used to be an NHS hospital, and it's now owned by the Priory Healthcare. And some services have gone much further down the private route than others. In 2018, the NHS spent 100 million on private providers for mental health services. This was about 30% of the total budget. The Priory Group received more than 45 million. It was actually fined 300,000 over gross failings that contributed to the death of a child, not at this particular hospital. Lack of mental health beds mean that patients can be transferred in crisis up to 300 miles away. This is supposed to be something that was going to be addressed by government. It hasn't really changed. If you look at child and adolescent mental health services, 44% of the budget for those goes to the private sector. And if you look at locked ward rehabilitation units, 97% of those are now run by the private sector. Here we have the offices of Capita on Sheepscar. This is an international process outsourcing and professional services company. Its major contract for the NHS is for primary care support services, and there's been lots of problems with that. A few years ago, for example, it was found not to have sent out correspondence to nearly 50,000 women about the cervical cancer screening programme. Just coming back to hospital trusts, 40% of non-clinical support services are now outsourced to private companies. Of course, most hospital clinical services are still delivered by the NHS. This is a staff recruitment office down in town. Before the pandemic, there were estimated to be 104,000 vacancies in the NHS. This put staff under extreme pressure, and there's a whole array of private agencies who are very keen to provide locum staff, often at rather high rates. Now, the NHS had set up NHS Professionals. This was a publicly owned agency that supplied more than 90,000 healthcare workers to NHS trusts in England and was saving the NHS 70 million a year by undercutting these private companies. What did the government decide to do? It decided to sell it off to the private sector. It was too successful. In fact, public pressure forced them to back down. But there's a similar thing now going on with the Oxford Vaccine Innovation Centre, financed largely through public money, doing lots of work on vaccines and vaccine development. And so the government have decided they want to sell that off to the private sector. There's this kind of obsession with selling things off that's a recurrent theme. This is a sign in Joseph's Well, a private company, but you'll see the NHS logo there. The Department of Health encourage private companies to use the NHS logo because they know that it's trusted by the public. They actually license it, and they have someone in Quarry House who helps private companies market their services using the NHS logo. At the same time, they actually threatened keep our NHS public with legal action because we use the NHS logo on our website and in our campaigning. And they said that would confuse the public and we hadn't been authorized to do it. We didn't take any notice. This is a private dental facility. And then down on the right, my own dentist, which seems to have been closed now for the entire pandemic. Dental care in Yorkshire is bad, and it's particularly bad in children. Nationally, Yorkshire stands out, and it's a disease that's also very related to deprivation and poverty. NHS dentists now charge for a wide range of treatments that used to be free, and they're a direction of travel that the NHS is going in. Private dental practices provide treatment that is not available on the NHS, such as dental implants, for those who, of course, can afford it. This is the hospital pharmacy at the infirmary. Pretty much all hospital outpatient pharmacies where you collect your drugs from to go home have been handed over to the private sector. Boots being one of the major players. And this is because hospitals had to tender for these services, And the private companies like Boots do not pay VAT on drugs, whereas the hospital does. So it's easy for the companies to come in and undercut the hospital and get the contract. And yet Boots is a company that makes huge profits out of the NHS at the same time as is a huge tax avoider. So is depriving the Treasury of money that's actually needed for public services. But this is now pretty much the situation across the entire NHS. This is a high street pharmacy on the Roundhay Road. And it's interesting because on the door, there's a poster which I've amplified on the right there. Need a doctor? Online consultations available now. Speak to an online doctor here and collect your prescription. I mean, that is actually against GMC advice that you see or that you don't see patients, talk to them over the phone and then give them a prescription. But this is a service that's available at £40 a time. And Boots have also started to offer this service in Surrey and London using a digital healthcare app called Livy. GPs say that this further erodes traditional general practice and important continuity of care. This is the light surgery in the city centre. Another example of a private GP practice. Note again the use of the NHS logo. It's part of one medical group that describes itself as a provider of innovative healthcare solutions to the NHS. This is a surgery in Crossgates. I'm not picking it out as being unusual or unique, but many surgeries now have contracts through the CCG with packages which have been contracted out to private companies, such as chronic pain management. So you see your GP, they'll refer you, but you're actually being referred to a private company. And Leeds Clinical Commissioning Group, the group of GPs who since the 2012 Act hold the purse strings and decide what is going to be purchased. Leeds CCG spends about 15% of its income on private providers. Some CCGs spend 25%. And yet if you say to them, well, don't you think privatisation is a bad thing? They'll say, we don't know what you mean by privatisation. There's no privatisation. You've got it out of proportion. This is the Meanwood practice. Nothing against them. I'm sure they're an excellent practice, but they're embedded within them is a private company that New Medica, which provides NHS-funded ophthalmology services. So just another example of how the boundaries have become increasingly blurred between public and private. Now, the health service, as you know, started in 1948, but the Beveridge report came out in 42 and provided the basis for developing a health service. And Willink was the Tory Minister of Health who did produce a white paper called a National Health Service. And it was very much a response to the Beveridge report, which did have cross-party support. And also the war had brought into sharp focus the fact that the health services were very fragmented and inadequate in the UK. Now, the problem with the Willink white paper is it was very half-hearted. The plan was that you could join the National Health Service if you wanted to, but no patients or doctors would be forced to join. It was anticipated that substantial private practice would continue. Voluntary hospitals, who are very important, could decide for themselves whether they wanted to join. And there were secret agreements with the British Medical Association. Bevan became Minister of Health in 45, and he said, no, we're going to nationalise all the hospitals and bring them together in an NHS. We won't have any secret deals, and it's the Ministry of Health that will have powers to build the service. And he actually eventually won over doctors by saying, we'll give you what you need to provide first-class medical care and for research and teaching to flourish. The Conservative response was that they consistently voted en masse against the bill, and they incited doctors to oppose it. Willink said that the bill, Bevan's bill, will destroy so much in this country that we value, that the plans for GPs were disastrous, and the Tory criticisms of Bevan was that he had abandoned the Willink plan. Now, it's important to remember that, because both Jeremy Hunt and Matt Hancock are fond of saying that the NHS was set up by the Conservatives. And what they mean by that is that they attribute it to Willink. But you can see from this slide and what I've just said that that's really a gross distortion of history. Now, going back to that slide for a moment, what it means was there are a lot of people who are opposed to the NHS, and they don't go away completely. They don't give up, but they're pretty quiet for a while. And actually, there was broad consensus on the NHS for about 30 years. But then we have the Thatcher government, 1983, a very key year. That was when competitive tendering for the provision of domestic catering and laundry services were brought in. There was then a long list of contract failures, but hospitals getting these contracts, in-house contracts, were overruled by ministers, and they made new rules which made actually terminating contracts was much more difficult. A lot of people now sign up to the view that the rise of methicillin-resistant Staph aureus and hospital-acquired infection was directly related to this tendering out to private companies of hospital cleaning services. A few years later, you have John Redwood and Oliver Letwin articulating what they would like to happen to the NHS through the Centre for Policy Studies. And they know that the public are very attached to the NHS. So they know it's going to be difficult and they have to do it in a gradual way. But these are the vision that they set out, is that the NHS should be made an independent trust, that they should foster cooperation between the NHS and the private sector, that they should extend the principle of charging for care, and finally, they would switch from taxpayer to insurance funding, and there would be inward investment from private companies in the NHS. 1988, we had the Griffiths report, which led to massive privatisation of social care and the mess that we're in with that at the present time. This was when the transfer of care of the elderly from the NHS, which was free, to local authority, which was paid for and means tested, happened. And 80% of government money to local authorities for social services had to be spent on the independent sector. 1989, Working for Patients White Paper, also known as Working for Peanuts and Working for Profits. This was a key event. It was the start of the internal market, where health authorities who used to hold budgets, but also had authority to provide services and to assess the needs of their populations, the internal market made them into purchasers along with GPs and then split them away from providers. This was the start of the internal market in healthcare, and hospitals were now supposed to become more like businesses, to compete with each other. They had to show a 6% return on the investment, and they were subject to capital charges, which was like a tax on their assets. This is one of the reasons why hospitals charge for car parking, because they're forced to make some return in relation to this capital charging that goes on. So the LGI has a city centre site. It's old, the buildings are not in good state, but they're assessed as having plenty of capital, and they're charged a tax on that basis, and they're forced to try and recoup it, which is why I think they made about 1.2 million from car parking charges last year. 1990s, just when I moved to Leeds, we had hospital trusts came along, and these were allowed to carry out more private work to increase the number of pay beds. There was a move to having more short-term contracts for staff so that you could be a little bit more flexible with how you use staff, and you started to see dilution of skill mixes with less well-trained staff taking on roles usually would have been done by more highly trained staff. And we also saw the rise of management consultants. 1991, private finance initiative introduced by John Major, also known as profits for industry or pure financial idiocy. These capital schemes have turned out to be a new form of public sector debt, and a very expensive one. Even Norman Lamont recognized that it was much cheaper for government to borrow money for hospital building than it was to have these PFI arrangements. And when Labour was elected, many of us thought they would ditch PFI. Margaret Beckett even described it as totally unacceptable, the thin end of the wedge of privatisation, but they decided to stick with PFI. The Labour government did, however, increase health spending, and this was to bring spending in the UK more or less in line with the European average, and it meant an increase from 6.3 to 8.8% of GDP. Now, this didn't solve all the NHS's problems, but it did mean more staff were employed, pay was improved, A&E performances improved, and the waiting list came down to 865,000 in 2005. Of course, now it's over 6 million and projected to go up to over 10 million. But there was also an arrangement, a concordat introduced with private hospitals where they were going to take NHS patients to do routine work, even though their costs were about 40% higher. And in 2001, the private finance initiative principles were extended to new builds in primary care. You also saw the first hospital being taken over by the private sector. This was the Good Hope Hospital in Sutton Coldfield. And this was billed as the flagship for public-private partnership, the way forward. But tribal sector very rapidly increased their fees for managing the whole affair, almost by 50%. They ran up huge deficits, and the NHS were forced to buy back Good Hope Hospital before it went completely bankrupt. The same exercise was gone through again in the Cameron years with Hinchingbrook Hospital taken over by Circle. This again was going to be the way forward, with private companies showing the NHS how to do it. What happened after a few years? Circle give it back. They can't make a profit out of it, and they give it back. And in 2007, the CBI were told by Labour, we now have an open-minded approach to who provides care. It doesn't have to be public. Foundation trusts were introduced in 2002 by Alan Milburn, and the idea was that they could actually have a lot more freedom and could to some extent opt out of NHS structures. Milburn declared the 1948 model of the NHS was now inadequate. Simon Stevens, who before he went to work for United Health in America, and before he came back as head of NHS England, was health advisor to Tony Blair. And he talked about the mixed economy, choice, surgical hubs being run by private companies, and private diagnostics and GP out-of-hours services being lined up for privatization. Interestingly, at this time, the Department of Health actually recognized the link between competitive tendering and falling quality, because competition on price drives quality down, despite the fact it's often sold to the public as doing the opposite. We had independent sector treatment centres built up to do work in the private sector, but only private companies could bid for these. NHS hospitals couldn't bid for them. And they took NHS staff and they took low-risk patients, and they had contracts that meant even if they didn't get many referrals, they still got paid plenty. and they ended up costing over 11% more than that work would have costed if the NHS had the investment and done it itself. And it's disappointing now to hear Wes Streeting, I think, looking back to these kinds of arrangements and saying they work well. Well, they didn't actually work well. They're expensive. 2004, we have payment by results, a misnomer if ever there was, because no one looked at the results of interventions or care. They just looked at what was done. But this opened up a mechanism. There was a tariff for operations, for procedures, and it opened up a mechanism to purchase care from private providers. And this was all part of the philosophy of breaking down barriers between public and private. Patient choice was very important in this. But of course, to have patient choice, you have to have surplus capacity in different places. And that's a rather wasteful thing. It was aimed that there would be 10 to 15% of elective operations done in the private sector. And this actually signaled the end of 30 years of efforts to equalize allocation of NHS spending on the basis of your population and local health needs. 2005, second wave of ISTCs, and they started talking about contestability, establishing a viable private sector, and that this would then drive up standards and drive down prices. Now, this has never really happened, but this was apparently believed by some people. Waiting list operations, people waiting for operations were transferred from the NHS to the private sector. And actually, this was providing 2/3 of the total turnover of the private medical industry. So the NHS supporting this rather small private sector. 2006 white paper, Our Health, Our Say, was pushing GP primary care trusts to put services out to tender. And there was a policy paper that stated delivering health and social care services are no longer the preserve of the public sector. The third sector, as well as private companies, have a valuable role to play. There's lots of notable privateers around. Here's Michael Gove, co-author of a book called Direct Democracy, published, I think, in the 2000s. This said the NHS fails to meet public expectations. Well, there may be some truth in that, but of course, there are reasons for it to do with underfunding and neglect. But it's no longer relevant to the 21st century. It's a national sickness service, a 60-year-old mistake. And they thought that people should pay money into personal health accounts and they could use those to shop around for care from public and private providers. Only those who couldn't afford to save enough would be funded by the state. We then had the banking crisis and the Nicholson challenge. Here is the Chief Medical Officer of Health, was that the NHS had to find £20 billion worth of so-called efficiency savings. In fact, in international comparisons, the NHS is very efficient, but it had to find 20 billion savings over 5 years. And then we had the 2011 Health and Social Care Bill, which actually amplified the market even further, putting competition at the heart of the whole thing. Again, allegedly, this was to drive up standards, but making tendering for many services compulsory with all the bureaucracy that involves. Establishing clinical commissioning groups. This was going to be fantastic. Who knows better than GPs what services should be bought? Well, GPs know a lot about general practice, but they don't know about the whole NHS economy. But they were going to be given most of the money and they would decide on services. Now, already by 2005, the Common Select Committee on Health had estimated that administration costs in the NHS had gone up from 5%, where they'd been for a long time, to 14% of total budget. And this was very much related to the market. The fact that you have to have all this contract setting and monitoring and legal advice and all kinds of things going on which cost money. And whenever at work we used to get questionnaires around, as we did from time to time, saying, come up with an idea for cost savings. And people would say, well, why don't you take the plug out of the photocopier and stuff like that? And things like, why don't we take away drinking water, which they did. That cost, that saved 30,000 a year. I always used to say, get rid of the internal market. That will save you 20 billion a year. But that was never taken seriously, of course. And then here we have Matt Hancock, who said famously, there will be no privatization on my watch, at the same time as giving 9.2 billion of the NHS budget to private companies. This was before COVID. This was before COVID. Of course, with COVID, things went off the scale. So we had the NHS and public health being bypassed and outsourcing of testing centres, test and trace, which was always called NHS Test and Trace, but was a private company, the Lighthouse laboratories for testing, Nightingale hospitals, staff recruitment, and personal protective equipment, all outsourced to private companies. And then Hancock tries to muddy the water further by saying, well, we already have lots of private companies in the NHS. We always have done. GPs are private. Now, we can debate that, but it's actually quite a misleading thing to suggest. And look what happened to some of those contracts. And also the profligate use of public money in the pandemic. And this is important because the government alleged that the current legislation is based on what we've learned in the pandemic, and they want to do more of it. But look what they did. NHS Test and Trace. It failed in its main objective, said the Public Accounts Committee. No evidence it reduced infection. 37 billion. COVID loans, these were not for the NHS, but for business. 16 billion lost due to fraud and error. Again, profligate use of public funds. The Department of Health, it's estimated that they've written off 9 billion on personal protective equipment, which is unusable. Around 2 billion of NHS cash was wasted on block booking private hospital beds in 2020. And actually only 7 beds a day were set aside for COVID patients, while the private sector trousered considerable amounts of money, but actually increased its private work. Empty Nightingale hospitals. Why were they empty? Because there were no staff. 530 million wasted on them. Matt Hancock said that the deal with the private sector to provide support would be transparent. Well, it isn't, and it still isn't. And the Centre for Health in the Public Interest, who do very good work, said it's all smoke and mirrors, and it's just very difficult to know the true arrangements behind the multi-billion-pound deal with the private hospital industry, except it suited that sector very well because it stopped them going bankrupt like lots of other businesses. The NHS did not get much out of it. There was a lot of cronyism going on before the pandemic, and this is a nice website, My Little Crony. Go and have a look at it if you haven't seen it, but it shows all the connections between individuals and businesses, the political donations, and the government contracts and the other connections. And it's an absolute spiderweb. And the management consultants and the lobbyists are right in there making the connections and ensuring that the money gets spread around, but not spent in the public sector. And now we have the health system support framework. This is from NHS England website, a support framework created to support the new move to population health management and the delivery of integrated care. And it's 200 private providers that are accredited third-party suppliers, about 30 of them being American multinationals. I think I'm on time. I'm aiming to finish within 45 minutes. Now I come to the Health and Care Bill. This is before Parliament at the moment, and it was trumpeted as getting rid of competition. And there was a kind of suggestion that we've learned our lessons, that the market doesn't work and we're going to reverse it. Actually, it's got nothing to do with reversing privatisation, and none of the privatised services are going to be brought back in-house. It was introduced in the House of Commons in July, and I think it can be seen as a major reorganisation. Alison Pollock summed it up very well, I think, in this sentence. It is an astonishing attempt to allow the Secretary of State an enlarged NHS and an enlarged NHS England as rule maker and regulator, and new public-private integrated care boards to reduce services, limit expenditure, further degrade local accountability, and entrench the market. And of course, if you wanted to get rid of the market that's been in the healthcare system now for so long, you would need legislation. You would need new legislation to re-establish the NHS. And David Locke QC said in 2019, the big picture is that if you have a market system, that you have it. If you do not want a market system, you want to run a public service, you need a different form of legal structure. Well, this is not being offered in the Health and Care Bill. It is supposedly about integration, although it's clearly not effectively integrating health and social care being incredibly fragmented and privately provided. The National Audit Office has actually said, show us the evidence that integration improves patient care, because we can't find any. It does mean that competition rules, the mandatory competition rules, are being abolished, and that's presented positively as getting rid of needless bureaucracy. But another way of seeing it is that actually having to compete for contracts in a transparent way is a check against corruption and cronyism that's really important when you have a market model. And what's happened during the pandemic is a clear example of that. The new system, integrated care systems, will, there's lots of ways that the private sector gains ground. One of them is through provider collaboratives, which involve private providers as well as NHS providers. And these are expected to play an active and strong leadership role in determining what services are going to be available, and are described as a principal engine of transformation. So if you forget some of the fuss about whether private companies can have representatives on care boards, actually there's plenty of scope for them to be involved in decision making. That means they don't actually have to have a representative on the integrated care board itself. I mentioned revolving doors, but here's a couple of examples. Samantha Jones, who was Director of New Care Models for NHS England, appointed in 2015. One of her jobs was actually to engage with the big American corporation Centene about inroads into the NHS for them. She then becomes Chief Executive of their UK subsidiary Operos, which now controls 50 GP practices, 2 of them in Leeds, incidentally, most of them in London, 500,000 patients. And then in 2021, she leaves Operos and becomes Boris Johnson's expert advisor for NHS transformation and social care delivery. Lord David Pryor, he has been a British Steel executive and worked for Lehman Brothers and Lazare Frères. Probably never used the NHS. He was appointed chair of the Care Quality Commission. Now, would you expect the chair of the Care Quality Commission in 2014 to advocate NHS hospitals are taken over by European or American hospital chains? It's exactly what he did. He also held up Hinchingbrook as being the golden model of the future that we should be pursuing. And then he's appointed as chair of NHS England. He's now left that post. They've appointed a new chair from industry, knows nothing about the NHS, actually, they admitted that he didn't know much about social care either when he was interviewed, but they said he could learn on the job. Now, let me just say something about funding. Governments say the NHS has never had so much money. That's true. If they only gave 1 penny more a year, that would be true. But for the first 70 years, the NHS had an average uplift every year on its budget of 3%, 3.7%, and that allowed it to keep on top of increasing demand, new treatments, or what have you. In 2010, with austerity, it all changes, and the average uplift has been 1.4% a year. What that means is if the NHS had continued to have that average uplift, it would be getting £35 billion more a year now than it is doing. And each year, it's had this kind of gap. So the cumulative gap over the last 11 years is 200 billion. And that's why it's struggling so much. With the current spending plans, by 2025, this cumulative gap will be 300 billion between what it would have got if it had had its 70-year average maintained and what it's actually getting. And this is causing a lot of problems. Look at the impact on beds. Now, this is just not the impact of austerity, but over the last 10 years, we've lost another 20,000 beds. Over the last 30 years, we've seen a 50% reduction in beds. Where does the UK stand in international comparisons? Well, these are beds per 1,000 inhabitants from 2020, and you can see you've got Japan, Korea, Russia, Austria, Germany right up on the right. But right down almost at the bottom, you've got the United Kingdom, and we are the sixth, I think the sixth largest economy still in the world. So we're up there with India, Mexico, Costa Rica, and Colombia. UK spending, this is healthcare spending per person in OECD countries. The United Kingdom is the yellow bar in the middle, and you can see that that is just above the OECD median. So that allows right-wing think tanks to say, oh, actually, the UK gets plenty of money. It just doesn't spend it very wisely, so it shouldn't be given more. But the comparison really shouldn't be with the OECD. Again, this involves countries which have very small economies. And if you compare us with 15 countries in the EU, then the UK spend is 81.5%. So for example, compared with the Netherlands, we're spending 1/5 less on healthcare than in the Netherlands. This is just critical care beds, which was highly relevant with the pandemic. Look at the UK, we're almost at the bottom. And you can see how worried the government were by those pictures of Italy, patients dying in the corridors because they had no intensive care capacity left. And they had 12.5 beds per 100,000, which was double what we had. Does it matter? Well, if we just think about private care, some people think it works better for various reasons. There's massive evidence. The best you can say is that it's not really possible to say with certainty, but there's actually a lot of evidence that suggests that private care doesn't work so well. And this is a study recently, comparative performance of private and public healthcare systems in low and middle income countries, a systematic review. Headline, private sector more often violated medical standards of practice and had poorer patient outcomes. Conclusions, studies do not support the claim that the private sector is more efficient, accountable, or medically effective than the public sector. Why I don't think privatization is a good thing. Private services restrict access. They have eligibility criteria. They do not want sick, very sick, complex patients generally. Price competition lowers quality, it doesn't increase it. It fragments services. You find patients getting different treatments, different services from different companies who don't cooperate together. The value of contracts are often difficult to determine and opaque. Staff paying conditions are driven down. 45% of the budget is on pay. So if you want to make savings, you cut pay and conditions are driven down. Continuity suffers. Contracts are dropped, like the practice group in Brighton suddenly gives up its 11,500 GP patients because it decides it's not profitable to do that. Circle drops Hinchinbrook Hospital and the NHS takes it back up. Patient safety is an issue. Companies repeatedly criticised by the CQC. BMI Healthcare in Kent, these are just a few examples, were criticised for prioritising financial targets over patient safety. Now, some NHS managers have been criticised for that, of course. And the Centre for Health and Public Interest have done detailed work on safety in private hospitals, showing that it is not good and showing that their business model is unsafe, the way that they use consultants from the NHS who they regard as self-employed. And this was highlighted by the Ian Patterson scandal. There are often unforeseen or unintended consequences. So a lot of cataract surgery now being done in the private sector. 200 ophthalmologists have just written to the Department of Health saying, look, staff who would normally do extra hours for the NHS are being lured away by better pay to do cataract operations in the private sector. The NHS managers are saying, oh, that's fantastic. We're getting more cataract operations done. But this means other eye procedures are not being carried out in the NHS and waiting times for those will grow. It also means there's a big training problem in the NHS with lack of training opportunities for ophthalmologists of the future. The private sector wants contracts for specific packages of services that will be guaranteed to be paid for by the public purse. Services go to the lowest price bid, and that's often the least reliable contractor. Overall, this is buying in services rather than selling off. So we're not talking telecoms here, utilities and railways, wholesale sale of the NHS, as some campaigners suggest, but it's buying in services from the private sector instead of investing in NHS. And the philosophy is about minimizing the public sector, holding down taxes on the rich and big businesses, handing contracts to mates. So privatization, it's a political issue. It's a political move to line contractors' pockets and weaken the power of organized labor. And you have a lot of outsourcing going on. The Great Ormond Street Hospital security staff are on strike at the moment. They're outsourced. They work in the NHS, but they're employed by Carlisle Support Services, which generated revenues of 65 million in 2019, before tax profits of 1.3 million. And they supply cleaners, guards, and retail staff. They're mainly owned by Lord Ashcroft, former Conservative Party chairman, who lives in Belize. And they get paid £11 an hour. They get statutory sick pay, £96 a week, which means you can't isolate if you've got COVID. They get very inadequate, if any, maternity pay, unsociable hours payments, or employer pension contributors. And most of them are from Black and minority ethnic backgrounds. This is repeated up and down the country. And they want to be on NHS terms and conditions. This is an interesting view from the USA. Now, the USA has the most marketized system in the world, the most expensive and some of the poorest outcomes. And this is an article in the BMJ by Woolhander and Himmelstein. And they commented that private health plans in the US selectively enrolled healthy people and ditched sick ones. And also that US emergency departments, A&Es, turned ambulances away once a minute. They just didn't need to have them. They were busy and they just sent them away. And this is some very important observations that they make in that paper. The US has long combined public funding with private healthcare management and delivery. Extensive research shows that its for-profit health institutions provide inferior care at inflated prices. US experience shows that market mechanisms undermine medical institutions unable or unwilling to tailor care to profitability. Commercialization drives up costs by diverting money to profits and fueling growth in management and financial bureaucracy. The poor performance of US healthcare is directly attributable to reliance on market mechanisms and for-profit firms and should warn other nations from this path. Investor-owned healthcare firms are not cost minimizers, but profit maximizers. That's what they do. Why haven't politicians taken warning? Well, the answer that Woolhandler and Himmelstein gave is that these market reforms, such as the ones that we've pursued in the UK, are a covert means to redistribute wealth and income in favour of the affluent and powerful. Last 3 slides, I think. CHPI have tried to look at how much money is going to the private sector. Department of Health say, oh, it's 7%. You know, it's never been much more than that. Get over it. So CHPI looked at all the outflows from NHS England, the Department of Health, where they went to, and the overall percentage of NHS expenditure used to buy healthcare from private providers, excluding GPs, is about 18%. And CCGs, as I said, about £1 in every 6 purchasing healthcare from outside the NHS. And David Rowlands, who is involved with that report, commenting on the current legislation, makes the very pertinent comment that as long as the NHS relies on private companies to deliver NHS services, it will require a highly effective form of market regulation to protect it against the well-documented tendency of for-profit healthcare companies the world over to fix prices, generate illegitimate income through fraud, engage in collusive and monopolistic behavior, and win public sector contracts through cronyism. Those who say the Health and Care Bill is about pushing back the market, pushing back competition, it says simply shifting the policy goal of the NHS from competition to collaboration does not mitigate those risks. So, going right back to the beginning, what is privatisation? It's all there and it's going on, and it's not getting less, it's increasing. And I've tried to show you that this is not a good thing for lots of reasons, and it's not the route we should be going down. The marketeers reject the concept of public service ethos. Medical professionalism is actually undermined because it's seen as a barrier to the operation of market forces. That leads to diminished trust between patients and professionals. And ultimately, it's likely to bankrupt the healthcare system as it's doing in the US. It also undermines the ethical foundations of medical practice. What we need instead is proper strategic long-term planning based on assessment of health needs. We need to actually take the market out of the NHS. We did very well without it. Take it out, get rid of its destructive forces, and return to a publicly funded, provided, and accountable public service. If you're interested in Leeds Comp, we've got our own Facebook page, a website. Those slides I showed you walking around Leeds, we actually have those in a nice little virtual gallery on our website, and National Comp has lots of useful information. So I'm sure I've spoken for too long and I will stop there. Thank you very much.
Well, thank you very much, John, for a very, very interesting and thought-provoking presentation. So I think we'll now take a break. Okay. All right. Okay, so Ashley, would you like to ask your question first then?
Yes, my question, well, really 2 questions. One, I used to be the CAMHS Children's Mental Health Commissioner in Leeds until 10 years ago, and I was never aware of giving any money to the private sector. So I'm interested in John's statement earlier on around a lot of high proportion goes to the private sector. But my main question is, why do so many NHS consultants also do a day or half a day a week in the private sector? It feels as if it's encouraging the private sector, and it may just be greed, but I'm very interested in John's response to that question.
I think it is. I think it is greed. I mean, they get paid a lot for doing it. I mean, of course, it depends what your specialty is, doesn't it? So, you know, when I was a neonatologist, no one did any private practice because there isn't any private neonatal intensive care. Similarly for mental handicap, and actually there wasn't much private practice in pediatrics, apart from in pediatric surgery. But I think people, I don't know of any other reason than that it was for money. I'm sure some of them would say they liked the variety. You know, it was quite nice to go out and do a clinic in more pleasant surroundings, less pressure, that kind of thing. But I don't think there is any other answer other than money is the motivation.
Thank you.
Okay. Janie, would you like to ask your question?
Do you want to say?
I was just asking a bit more information about how health outcomes compare in the UK compared to, say, other European countries, and also how those relative outcomes have changed over the last 30, 40 years.
Okay, I mean, Reinhard might be better placed than me to answer that. I mean, I think in some respects our outcomes were not as good, and so in the international comparisons, the Commonwealth Fund comparisons, although we would come out as #1 overall until recently, where poor access has driven us down to 4th. Outcomes tended to be lower, but not that different. And I'm not an expert on that, but I think our politicians are fond of saying we have terrible outcomes compared with Europe. But of course, I would say when the outcomes are worse, often that does relate to overall to funding. So, you know, if you spend, I remember David Cameron saying things were much better in France, much better outcomes. They're spending 30% more on their healthcare than we were. And if you look at cancer, for example, you have to be diagnosed early. So you have to have a rapid referral pathway, and then you have to have skilled people, and you have to have good equipment. We don't have that. Now that's supposed to be something the government are addressing, but how are they addressing it? By getting private companies to build and run the diagnostic hubs and poach staff from the NHS. That doesn't seem a very sensible approach to me, but that's their favoured model. So I think our outcomes actually have been pretty good, far better than some outcomes in the States where they spend this extraordinary amount of money but actually have very poor outcomes. We didn't do very well on things like infant mortality compared with many other European countries, and that's often taken as a kind of proxy measure for kind of overall levels of healthcare. Reinhard, do you want to comment on that?
Yeah, if you want, I can comment, because I think what you say is completely correct. It's the funding. I mean, Germany also has, as you showed in your slides, much higher funding. And so in cancer's treatment, for instance, the outcomes are better. But I think that exactly also highlights problem of the situation, in my opinion, because Germany and France have a social insurance system. It's not directly dependent on the government, and the government has relatively limited control about how much money is used. I mean, they have some, but limited. So in Germany, you have also the situation that 10% of the upper echelon can opt out of social insurance system. But in the UK, you have a system, it's financed by everybody. And I put it quite provocatively, the rich have no interest to finance a general service, and they have good control over the government. So it's much better to go for private services and leave the other services for the rest. In the United States, you have a similar situation. You have excellent, in my opinion, excellent outcomes at the top, the best of the world. But on average, it's quite bad because many do not get the best services of the world. When I visited once the health services in the United States, was working in Wakefield at the burns unit, I learned in the United States there is highly specialized burns care, but it's only available for private patients and the lucky few who are on government services. So you just don't get into the private burns unit because it is basically the beds are not available. The same applies to accident and emergency. If it's a private hospital, they can just refuse to accept you. So, I mean, I don't want to go on because otherwise I take over the session. So, and I don't want to do this.
Okay, well, thanks for that.
Thanks. Yeah.
I mean, I don't know how many of you know the Commonwealth Fund. It's nothing to do with the British Commonwealth. It's an organization in America that looks at other countries' healthcare provision as a way of providing lessons to the American government if they would learn them, which they don't want to. But it compared the health systems in the most advanced countries. And for years and years, the NHS, on a series of measures, such as affordability, accessibility, efficiency, outcomes, waiting times, came out as number one. It's only, I think, last year in the most recent report that we dropped down, and that was largely because the difficulties people are having accessing services with increasing waiting lists and the problems in general practice.
Okay. Thank you. Maybe Reinhard, you've got the next question, but shall we just ask the second part of it about the changing, how you would change the direction of the NHS? Do you just want to ask that?
I also quickly want to ask the first one, because John put private and public, I mean, said private for profit, private non-profit, was all in your presentation the same. So I wanted to ask you, how do you justify it? Because I feel there's a huge difference between what I call social or private non-profit services and private for profit services. And the other question is, yes, you indicated that I mean, Labour and Conservative governments have contributed to this change or dismantling of the NHS. So what is your suggestion or proposal, the strategy for change, for political change? Because I think it's important in order to have a sort of outlook what needs to be done in the future. Thank you. And I want to thank you. Excellent presentation. I learned a lot from it. Thank you.
Thank you for that, Reinhard. Well, I think my justification for including non-profit services is that they would come within the overall definition of privatization of services if you're devolving to non-profit makers. Now, whether how much they have a role, and indeed, it's not something I think I'd be able to discuss very much, but I think sometimes they've been used to undermine NHS services, and I find it difficult to give much background there, and I'm sure you know a lot more about that than I do. But what I'd say is, I think that comes bringing in the non-profits has been a way of undermining state provision, and I think you can incorporate it within that definition of privatization. That's not to say necessarily that they couldn't have some kind of role, but I can't expand on that. Strategy, you might want to come back on that and educate me. Strategy to change direction. I think it can only be through public pressure and through through strong trade union organisation, which we don't have that as much as we used to, perhaps. But some of the unions have got more engaged over health service issues recently, which is good. But I think it's impressing on politicians that what they're doing is not good enough, and it's not what the public wants. But it's really really difficult, as you know, and I think in some ways the pandemic gives that sort of opportunity for a rethink and a recalibration. But it looks like the government are learning all the wrong lessons rather than the right lessons. When Richard Horton from the Lancet talked to Comp last year at our AGM, he was saying, this is a kind of portal, and that citizens should now be looking to governments to provide protection for them, which means strong health service and strong public services. Independent Sage are saying the narrative has to be changed so that health and social care are not seen as negatively as drains on society, but are actually seen as something which improves quality of life. So it's how that narrative is changed. It's certainly, those are the kind of things which I'd like to see opposition parties taking up, rather than going along with this neoliberal consensus that they seem to have gone along with for so long. But not much signs of that happening at the moment either.
Okay, thank you. Malcolm, do you want to ask your question?
Yeah, I just wonder if I could pick up on that discussion about not-for-profit and profit. And I think I agree with John in the sense, well, given where we are now, if we were moving to some element of not-for-profit, that is elements of privatisation. On the other hand, I think it might be useful to compare, and Reinhardt may know about this, and the way in which not-for-profit have operated in other countries as compared to for profit. I think much of the concerns now in terms of as it were, foreign corporations coming into the NHS is that it's profit corporations from the US that are coming in, whereas my impression is that most of healthcare in Europe is often not organised on effectively on a not-for-profit basis from charities or local, effectively charities from the past. And even in the United States, because I don't know what the evidence is in terms of comparing them, but I think I've read somewhere recently that half of the hospitals in the US are run on a not-for-profit basis. And I don't know if it's so much in the health service, but in other areas of public utilities in the US, I think it often turns out that those which are run on effectively on a not-for-profit basis are rather better than those that are on a profit basis. So I don't know whether you've got any views about what the role of not-for-profit would be as compared for profit. But while I've got the floor, maybe I can go on to ask my other question, which is, are the forces at work within the health service, in terms from medical professionals and others, pushing for privatization and marketization, or is it much more coming from a drive for from ideological forces, and combined with what are the interests of effectively the finance sector and consultancy? And I think using the example of PFI, it seems to me that the only people that gained from that were finance and and consultants, and the rest of us lost out. So, but if you, as we agree that I don't know where it was in your mouth, but if you think that it's going much more from ideology and finance, it seems to be it's going to be very much more difficult to halt than if it were coming from, let's say, from medical professionals and others interested in the medical services.
Okay, well, starting with that last point, I mean, clearly there are some doctors who are very entrepreneurial, and there's a lot who are now involved in companies that sort of contract the NHS, and this is a subject of one of the recent Centre for Health and the Public Interest reports, and was covered in the paper a week or so ago. But I don't, you know, most NHS workers aren't like that, and of course, it's only doctors, it's only consultants who do private practice. No one else does it. It's always been one of the arguments against it, that it's a sort of crazy situation where you just have one segment of workers within a hospital who are able to indulge in generating extra income from themselves. And I think most people. So most workers in the NHS have no interest in privatisation whatsoever, I don't think, and a lot of them, of course, are against it. Doctors, it would be a mixed picture there, but most doctors, I think, would still be very supportive of an NHS. But like the rest of the population, they tend to interpret the problems they have at work as being because we can't afford a decent NHS, and therefore it needs shaking up. And I think they're quite often uncritical about what's going on. And this is true of the Royal Colleges and the Academy of Medical Royal Colleges. Partly they've got an eye to maintaining their own status and their own privileges. And they don't like being political and being seen as critical, but they generally tend to welcome any new white paper and see only the good in it rather than seeing all the pitfalls. But I don't think there's I think for people, for the entire workforce, I would say there's much more of a push that would be against increasing privatisation. Certainly that's the focus of the unions, and there's still quite a lot of people who are union members. For profit and not profit, I mean, that's not something I've really thought about a lot, but it seems an odd situation. For example, the British United Provident Association, which is a large private provider, is actually described as not for profit, and I never really understood that. And I imagine it's some sort of tax status, but it doesn't stop them, poaching NHS staff and undermining NHS services. I mean, I'd like Reinhard to come back in and explain a little bit more his thoughts about that. I think a lot of it's driven. I think a lot of it's driven by ideology. It's those kind of neoliberal outriders who start suggesting that things could be very different, and slowly it becomes mainstream and then implemented. And then what's happening at the moment, I think, is there's a real feeling that the NHS can't do what it should be doing, that we can't afford it, and people are being driven to use the private sector if they can find the money to do it. So it's interesting that now the big threat is not so much about selling off services. It's actually about the sort of chronic underfunding that gets worse and worse and worse, and people voting with their feet if they can afford to do so. It's very, very worrying. But I think we shouldn't forget also the NHS is still very highly valued by the population in all surveys. And of course, doctors and medical professionals are still very trusted as a group, which I think gives them a responsibility to speak out, of course, which many of them seem reluctant to do, but that's another issue, perhaps.
Thank you very much, John. I think the next question is from Stephen and Dawn. you like to ask the question, Dawn?
Hi, yeah, it's just Dawn actually today. Yeah, really interesting talk. Thank you very much. Yeah, interesting also what you said about public pressure, and that the only way to look at privatization is through to maybe try to stop it, if people want to try to stop it, is through public pressure. But I just get the impression that, I mean, people that I know, they're not even aware. And I say sometimes to my friends that, you know, the NHS is just gradually getting privatized, and people just look at me like I'm mad. And yet then I'm not surprised, because what you've said in your talk about NHS logo being everywhere and NHS test and trace, even when I just say to people that's not the NHS, people just don't get it. People are just too busy with their normal lives, and so I can't see that happening in the future. That's just a general comment. But and I was interested as well about what you said about not-for-profit, because as you were talking about the not-for-profit privatization, private sector, it hadn't struck me that any of these outsourced companies were actually not-for-profit, because I can't actually understand what their incentive would be if they weren't trying to do it for profit. But as you say, maybe it's tax incentives. But my question was about comparing the UK with other European countries. And does, as far as you're aware, maybe Reinhard will be able to answer this as well, do other countries act in the same way as us in the way that we are outsourcing? So it's not that you've got private healthcare and public healthcare, or the NHS, it's that you've got the state NHS system outsourcing and privatizing that way, outsourcing their services. Is that happening in other European countries as well? And if so, what are the effects of that?
I think the answer to that is yes. And, you know, Sweden's done a lot of incorporated much more of the private sector, I think, in healthcare provision. And I think the same criticisms could probably be applied in those countries. I mean, interestingly, New Zealand's an interesting example, because New Zealand went down this route of marketization, and then, I don't know, it's about 10 years ago, said, actually, it doesn't work very well. We need to change course, and went back to much more like a state publicly provided health service. So sort of did change tack dramatically. I mean, there are countries like the Netherlands where, you know, they spend a lot, they have very good services, good outcomes, and they're sometimes held up as models. But I think the key thing about them is that they're all more expensive than the NHS. So there are, you know, there are think tanks that sometimes say we should be adopting more of a European model for healthcare, but they never say, of course, that will cost you more if you do that. So that's an issue that's avoided. That wasn't a very clear answer, perhaps, but I think New Zealand's a very interesting example of a country that went into reverse, having gone a long way down the market reform route.
Thank you. And Reinhard, what happens in Germany?
I mean, the German system is very complicated. So you have sort of private and public providers. You have social insurance, as I said, which is not for profit, but it's not controlled directly by the government. So the social insurance is basically organized by the members, normally through your employer, but it can also be a local public social insurance for people who are either independent artists and so on. And it's non-profit making. So at the end of the year, and that explains a bit what John says, they look at their expenses and their income. And when the income is not sufficient, they increase the rate. So when I was in Germany, I paid about 16% of my salary for health insurance. And the providers are private, for-profit, private, non-profit, and a mixture even of state providers. So like in Germany, you have municipal hospitals, you have hospitals of the Red Cross, you have hospitals and the GPs, for instance, and many specialists work in private practice. So it's highly complex. It's definitely as John said in his presentation, it's quite not as expensive as Switzerland or the United States, but it is quite an expensive system.
Thank you.
So, I mean, but I also would add, I mean, like John said, CT scans, others are expensive. So I think the whole, I mean, I think that the UK system is very efficient, but it's, I agree with John, underfinanced. And the problem, in my opinion, is that is one of the essential problems of the NHS, that the government has no interest to increase the finances for the NHS.
Mm.
Okay. I think, Jack, would you like to ask your question now? Jack? Do you want to unmute?
Oh, I'm unmuted. Right. About the role of private equity as a driver within the system. I think as we're in Cafe Economic tonight, if we can get onto the economics of what's going on here, because I think it's all a question of this privatization is all part of a neoliberal process that we're undergoing. I mean, we've seen all the many public services privatized, and basically we're left with just the NHS, which is so much of it's been outsourced that we're nearly to full privatization, as I would see it. And I think one of the drivers is private equity as well. Would you like to comment on that? I mean, I've got an example in dentistry with a chain called My Dentist, and the driver here is an American investment company called Carlyle. Now, this chain, which we have in this country called under My Dentist, is a very large chain of over 100 dental practices. And I'd actually like to comment on my own dental practice, which has just gone to another chain. It's actually located at Moortown Corner. As John's been taking photographs of places around Leeds. It was owned by dental practitioners who sold out to this chain, which actually is a British one. But interestingly enough, what's behind it is private equity. And I find this is probably a significant driver. Would you like to comment, John?
Well, I don't think I can comment in detail, but I'm sure you're right. And, you know, I think this is a very significant concern. And, you know, when recently Sunak was over in California and speaking to tech companies and no doubt offering them free access to NHS data. And there's a lot of there's a whole variety of companies that are very keen to get their hands on that and to exploit it, and that's probably going to be given away by the government. So I don't know if I can say any more. I agree. And you mentioned, further down, you just mentioned Virgin as well, suing the NHS. They lost a contract for children's services in Surrey, and they then sued the NHS and got several million, I think, a couple of million compensation for doing that. So that was an example of the way they really throw their weight around and were happy to take money from the NHS, even though they didn't get the contract renewed in the end. Have you got any other?
Now that's the end of the questions on the chat, I think. I can't see any more. Would anyone like to ask a question from the floor? Anybody else? Well, I've got a question if nobody else has, which is what you've been saying, John, is very much, you know, that the things are going badly. But the NHS, it's still free at the point of use, which is one of the things NIBEV here now, but some of these services are actually quite beneficial to patients. For instance, I'm just trying to remember the name of the outfit that I've been to that does ophthalmology, living care out at Thorpe Park. Now that is very efficient. You go there, you don't have to pay. And there's also the eye surgery done on further down Chapeltown Road. I mean, this is an advantage to the patient. So why do you not want this then? Why do you think this is bad?
Well, I think there's no reason why the NHS can't be innovative, but it has to have the investment to be innovative. And the problem is that the money goes not to the NHS, but to private companies. And then the NHS is even worse off and less likely to be able to be innovative and develop services. So it's true that those services may be good, but they're undermining the NHS. And you see that with the cataracts, you know, where the cataracts in the private sector funded by the NHS go up and up and up, but then destabilize training and provision of NHS services. Does it matter? Well, it matters because it generally costs more. I mean, that's one reason why it matters. It costs more in the private sector. And there just seems to be crazy things going on at the moment, like the recent contract with the private sector for about 250 million for the surge capacity. 3 months, they've just been asked to make beds available if needed, but they're being given about 250 million. So I think it's like with the independent sector treatment centres. Sure, they could do perfectly good work, although the quality in some of them wasn't very good. That was a problem. But they're costing more, and they're taking investment which could go into the NHS. So those companies that, you know, when you don't pay up front, that means that the NHS funding is going to those companies rather than the NHS. And I don't see why it can't go to the NHS. And it would generally be cheaper. I mean, even Amanda Pritchard, head of NHS England, has pointed out that the current arrangements with longer term reliance on the private sector is actually expensive and destabilizing the NHS. If there are services such as those eye services, which in a sense are innovative, that's great. There's no reason why the NHS can't do that. It can only do it if it has the investment. And what I've been saying is that ideologically, there's this drive to funnel money to the private sector. And that's been absolutely exemplified by the pandemic. You know, it's difficult to have a more clear example of how wrong-headed that's been, and actually how it's been disastrous in many ways, and has added to the huge death toll. I know that's going off at a tangent a bit.
Can I
invest in the NHS is my answer.
Can I comment continue on where John's been talking about ophthalmology from personal experience? Because under COVID, I was due to have a cataract operation done at St. James's, but because they were overwhelmed with COVID at the time, they had to refer me on, and I was referred on to New Medica, which is actually just next to Chapel Allerton Hospital. Now, I got very good care there. I was actually seen during the week by a locum ophthalmologist, wherever he'd come from. They've got all the equipment. I guess that because I think they are a part of Specsavers, that the finances come through that organisation. But the consultants who work there's 2 consultants, but they're both NHS consultants. One's from Bradford Teaching Hospital Trust, and one is from Leeds Teaching Hospital Trust. And when I was actually operated on, it was on a Saturday morning. Now, obviously, it was very experienced because he only took 10 minutes to do my cataract operation. But that's how they're running it. The consultants weren't doing the operations during the week. They had a locum to do the assessment. And then on the Saturday, the surgery, on the Saturday morning, the surgery was taking place. And interestingly enough, I think one of the NHS, one of the nurses working on the Saturday was an NHS, was a nurse who would be working in the NHS during the week. So that's how they're running it. New Medica themselves don't just have this clinic in Chapel Allerton, they've got clinics all around the country. But the way that it's all been built up is partly probably through finance from Specsavers, but also because it's been financed by the taxpayer. And that's how the private sector is building itself up.
Yeah, I think that's a good point. And of course, the private sector doesn't train staff. They take them from the NHS, and they don't share risk with the NHS. They will select the less risky patients. I mean, it's obvious that I don't think they would have taken sort of a 90-year-old with comorbidities for a cataract operation in case they needed to go to intensive care afterwards and just stop breathing. So they do cherry pick, and they do rely on NHS staff very much. So I think you have to look at their overall impact.
In fact, it's interesting you brought up about the Spire, which is of course on Jackson Avenue, isn't it, in Roundhay?
Yeah.
Right. It was under another name a few years ago. I had a friend who had heart surgery, going back in some years, and when he developed, in fact, they were overcharging him. The insurance, the way it was working, and in fact, his consultant negotiated to get a reduction because they were doing things that they shouldn't have been doing in that hospital. But also he developed complications, and in the end, he ended up with having to be transferred to St. James's to be treated. And this is another problem, that when complications ensue, they don't have the facility to deal with it.
True.
We could go on to the American system where where they don't allow you into the emergency room if you don't, now people can just turn up to A&E when it's you're in the States. If you don't produce your insurance, they don't let you in. And when and if you can afford to get in, and you can't continue to pay, they turf you out and send you somewhere else, wherever it might be. That's where
well, I think we could carry on with this for a long time, couldn't we? With all,
I can recommend you a film to see.
okay.
It was made some years ago by Michael Moore, an American documentary maker, on a film. It's been on TV a long time ago, called Sicko. And if you want to know where we're ending up at the moment here, unless we can drastically change it, that's where we're ending up.
Yeah, very good film.
Okay. Well, thank you. I think it's 9:30, and I think we'll perhaps, John, thank you very, very much indeed. I think we've really had our money's worth, haven't we, this evening? So thanks very much. So let's give John a clap, and thank you very much indeed.
Thank you very much.
Woo, woo. And thanks very much, everybody, for coming, and hope to see you again on April the 5th.